Hello and welcome to episode 2 of Arusa, where we explore the myriad meanings of the menopause transition from the perspective of African women. And today we're joined by a friend and somebody who I've been very excited to have. I've been asking her to be on this podcast for a long time, Dr. Kabugo Kamau. And Dr. Kabugo Kamau has lots of feathers in her hat. So we're just going to discuss a few today. She is a clinical pharmacist. She's also the founder of the Women's Health Cafe, which some women in Nairobi and probably the diaspora have heard of. She's a menopause educator, practitioner, and a member of the North American Menopause Society. Karibu.
Thank you.
Yeah.
Thank you for having me.
I've wanted to talk to you about this for a really long time because I think of you as one of the pioneers in menopause in Africa. And when I say that, I don't mean, no one's been doing work on menopause, but your approach and how you've really sought to educate and engage women in community and looking at menopause as something that we do together, I think has been very, very helpful for me, I know personally, but also rather new. Maybe you can tell us a little bit about that and why you did it.
Yeah. What we need to understand is, I guess in the older communities, there was systems that supported women in all aspects of our journeys.
Yeah.
However, like we talk about it all the time, now we are living longer. I don't know that there was ever a system to assist women through menopause. I think they were supposed to be dead by then. So we have to kind of create our own, right?
Mm-hmm.
So that was part of the reason why the Women's Health Cafe was developing. I mean, it was started because here we are. Our mothers didn't say anything to us or are not even there to say anything now if they wanted to. And so we have to develop a system that works for us. And community is so big in health. I mean, in our health, our psychological health. I said, let's first find a community where we can support each other in whichever way. And of course, the motivation to do that was many other things. But the primary thing for me actually was education, because without the education, you're not going very far as an individual trying to maneuver this stage of life. So the first thing we did was now with a motive to educate, we created a community. Yeah.
Okay, and maybe tell us a little bit more about this community. I'm a member, full disclosure, and I love it there. I think one of the things that people think about when they think about community is they think, you get together and you meet and you're all friends. What is the Women's Health Cafe? What is that community?
So the community started with just me. And I said, I will not advertise. I will not put it out there to anybody. I want women to come join the community, experience the community, and let them be the ones to bring who they want, who they think would benefit. So there's no advertisement anywhere. I add every single member myself. And that way, I know that the person who has come because somebody else has spoken to them, a sister, a mother, whatever, has told them, you must come into this space because I'm finding it beneficial. And I think it will be beneficial for you. So everyone asks me, how do I get there? I'm like, just know somebody who's in it.
Yes.
Yeah. And it's a women's only space. So it's a lot of mothers, daughters, colleagues, all women.
Right. Yeah. And it's on WhatsApp.
Yes, it's on WhatsApp.
It's also on Facebook, I believe now.
Yes, because I had to find an avenue where I can also now inform the men as well.
Okay.
And the different ages. Of course, Facebook is the old people's Insta or whatever.
It is.
But it was a good place to start. But I realized with 50% of us going through this and we're living with the other 50%, we needed to get this information out there. And I thought Facebook was a good place to start.
Okay. So now you have a women's only community with the Women's Health Cafe, and then the more external facing for, everyone else, even those who are not in the stage of the menopause transition on Facebook.
Yes.
Okay. And I'm a happy member of one of the many groups, and you'll tell us about some of those groups as we go along. But I wanted to speak with you specifically today about something that we don't hear very much about, which is menopause in the context of public health. It's we've spoken about this, and that's what we're doing actually, even in the community, is we're individually educating each other about this transition. how should societies be approaching the menopause transition from a public health perspective?
So let's think about public health and what public health really is. It's the science that prevents, promotes, prolongs life, prevents disease, promotes healthy living, and prolongs life in a community that, in a population that affects, in a demographic that affects very many people. Now, menopause affects 50% of the world's population.
Yes.
I mean, how bigger can it be?
Yeah. Not much bigger. Yes.
So when you think about it that way, then it is something that should be way up there in all health policies. All governments should be talking about menopause, because 50% is a lot of people that it's affecting. And then remember, it affects another 50% that we live with, the men.
Yes.
Right? So it's really affecting the whole community, not just the individual.
Right.
And which then makes it a public health concern. Yeah, just by the sheer numbers that it affects.
By the sheer numbers.
Yeah.
So then, if it is a public health concern, why is it that we're not seeing a public health approach?
Let's first talk about the fact that menopause, I think, has I think you asked me this earlier. Why has it surprised everybody? It's because we weren't living this long. And then now we're living this long, but we were so focused on childbearing age and teenage adolescence period. And we were so focused there. And I think we were silenced a long time ago, like I said. And so the women have been going through menopause. We're not the first ones. There are others who came before us, but they were just culturalized not to say very much. And so nobody was hearing anything. So we just kept on going without addressing that issue. And then I remember, for example, when my mom was about menopause age, I guess, she was forced to retire because, so once she retires and she goes home, there's nowhere else she really has a voice other than in her house. And then her children are gone. So there's really, she must have been talking to herself about the symptoms or the walls,
Right.
But we just regress, and not to regress, we just go into our little hiding spaces, because menopause comes with so many of those isolating symptoms.
Yes.
Depression, anxiety, and so most women just prefer to withdraw and be quiet and tough it out.
Right.
Fortunately, we were the generation that is going to empower others and empower ourselves through this. Yeah.
I love that. I do. And it is important, because even as we say that we're not the first, obviously we're not the first. Other people have transitioned before, successfully, not so successfully. I think that's the other thing that is important to realize. The more we understand about the number of symptoms, we were talking about this, we're connecting the dots backwards. We're saying, oh my gosh, is that what was happening? I know a woman who had hot flashes for really over a decade, until it was so normal, like no one ever talked about it, but she would be pouring sweat and have a washcloth because a handkerchief was no longer enough. And, there was no discussion,
Yeah. And I think also as we grow through the years, we find ways to explain it. You can even just say, it's just my way. It's just me. Me. That's me. I sweat a lot.
Right. Yes.
Or that's me. I get palpitations a lot.
Yes.
Or that's just me. I have heavy periods or crazy periods. You just now individualize it and decide it's just you.
Right.
And so what's there to say about it beyond that? It's just me.
Yeah.
Even when I talk about my personal experience, I always had low blood pressure and had low blood pressure. And many times I would only know if it's low when I have the dizziness and I have a palpitation. But then I started getting palpitations even without the dehydration or the low blood pressure. And I'm thinking, okay, why am I now? I'm well hydrated. My blood pressure is fine. And then I realized, that was that, like you're saying, we're working backwards. I'm like, so that's what that was. Because then I went to the doctor, I went to the GP, checked nothing. I went to the cardiologist, checked nothing. And I'm thinking, okay, something else is going on. But then I now became, that's just me. I get those sometimes. Because I already went to the doctor and said, they said there's nothing wrong. So I
Yeah.
said, oh, I get palpitations every so often. That's just me.
So we're just revising our definition of ourselves to
Yes.
incorporate these symptoms, these signs
Yes.
and symptoms,
Mhm.
but not actually addressing them.
Yes.
Yeah.
Mhm.
Okay. So it sounds to me then that even as a public health issue, and as we wait to develop policies and do all of this, that for doctors and anyone in the healthcare community, there really does need to be a bit of a checklist for perimenopausal women and women in the menopause transition.
Mhm.
So when you show up and you're saying, like, I was showing up with mood swings, my mood swings were insane. That was the thing that took me to the doctor. And we were talking about this, the thing that takes you to the doctor versus everything else you're experiencing. And so if there isn't a conversation with the healthcare provider and they're not asking questions about what else is going on, right? Not what brought you here, but what else is going on. And let's talk about this phase of life that you're in and what some of the issues might be.
And in our training, there's a line, when they say name, date of birth, last menstrual period, there's a line item called chief complaint. Now, chief complaint is where we put our focus.
Yes.
So let's say you come to me as a middle-aged woman and you say, I have insomnia.
Yep.
That's your chief complaint, right?
Yes.
But you might also mention that, you have achy bones or whatever. And I'm thinking, no, let's focus on your chief complaint, which is insomnia.
Yes.
So then what happens is we run off with that insomnia, and then the other symptoms are not addressed. And when you think about menopause, it's a combination of many symptoms. It's not just one for many. So I think that's where we miss it, is when now we're like, it's chief complaint and nothing else. Because if you ask many menopause women, if they sit down and list for you, they have 10, 15 symptoms. Some come and go, some start, stop, and then a new one comes, and then they overlap, So I wish that doctors would learn to now approach women in this age group differently. It's not about chief complaint.
Yes.
It's about where we are at in our lives and what's going on in our lives and in our bodies. Then you can address the whole person, not a chief complaint.
Not a chief complaint. Well, I want to go back to another thing that you just mentioned there, a date of last menstrual period, and I think about that and I'm like, there's so much focus on my menstrual cycle.
Yeah.
Right? And even when it starts to be irregular, the focus is still on my last menstrual period, not, hi, we're having irregular periods now. This might indicate. So it's not even, it's as if the public health and the medical training is so geared to our menstrual cycle for reproduction.
Around it.
As opposed to as an indicator even of our transition along the various phases, right? Including into the perimenopause transition. Because we are definitely listing that date. It's just that no one's giving us a conversation about it.
And also what I realize is for most practitioners over the years, that LMP was really to rule out pregnancy. Like, okay, so she's not pregnant. So I can give her this medication. I can do this procedure. That's the main thing. It's not usually, could you be menopausal? Could you be perimenopausal? No, it is, in fact, they'll investigate. If you haven't had your period in a while, they'll investigate why not,
Right.
So then you're going for hormone testing, you're going for this, you're going for that. But essentially it is you're in perimenopause.
Right.
But it is to determine, are you pregnant? Are you not? What can we give you now that you're not pregnant? Or do we need to further explore pregnancy? You see?
Yes.
Yeah.
Again, we're limited.
Yeah.
So there is a need to reframe and expand the thinking around treatment for women.
Yes.
Especially and based on that last menstrual period, right?
And in fact, some women, in perimenopause, half the time, many times you don't really remember. I don't even know why they ask you to just drop it like that. Like you're supposed to remember 2nd March 22, 3rd, 4th. No, I don't, sometimes I'm like, I don't remember.
Yeah.
But it was there last month and they're looking at you like, more information, please. I'm like, my life does not revolve around my period.
Yes. Yeah. And I think that's one of the things that for me has been super important about tracking symptoms. And I think it's signs and symptoms. for very many women, the period is a thing that we are asked. So some people track it. Some people it's very regular, so they never even needed to. They just know, fourth, whatever. But I know what you're talking about, because I go there sometimes and I'm just like, okay, just let me. I know it was at that function, and then I have to just. But it's really not that important. Except as we start to enter this phase, it does become more important to start to track it.
Yeah.
In fact, in some ways, more important, because pregnancy is, it's a defined thing.
Yeah.
This thing is a whole other whole other bag of chips. I mean, it's much more complicated. So understanding the irregularity vis-a-vis what else might be going on becomes as important, maybe not more, but as important as knowing whether you're pregnant or not.
Which is why I'm loving the new age where we have apps, where you can tell the doctor, okay, let me check my app and I'll have it right here. Because I was one of those who was like, I don't know. I know it came. It wasn't, I would imagine if I was trying to get pregnant or I was trying to track, then I'd care about my last menstrual period. But of course, I didn't know in perimenopause that I was supposed to be keeping track to see when they go crazy and when they don't go crazy. And, so I just
when
did
you
my
stop
life.
buying the pads and then, you suddenly have this accident. And the tracking is one of the reasons why we at Orusa are developing this app. And it is because for African women especially, all of our data comes from other countries.
Correct.
And there isn't any data that's telling us what happens to people like us.
Yeah.
Right. And that's not because we want data that's prescriptive. Every experience is different. But first of all, to understand, it is important for us to track. The fact that it's a natural process does not mean that it doesn't have interventions and also doesn't have risks.
Correct.
So it's important for us to be tracking these symptoms and signs as much as possible. And the more information you're able then to give to a healthcare provider, the more informed a medical decision they can give you as well, right? Because if I come in and we've talked about this, I'm reporting a certain cluster of symptoms, there might be different concerns versus if I've got symptoms that are sort of all over the place. But there are clusters of symptoms that can point to particular diagnoses.
Yes.
Yeah.
Yes, for sure.
So I think that reminding women that it's important to track. That, tracking your period is great, but in fact, as you even stop being interested in getting pregnant, it becomes even more important to start tracking these other things, even as they disappear. I mean, I had frozen shoulder for almost like 6 months last year. Yeah, about 6 months last year. And I was doing physio and all of this stuff. And then it slowly eased off, and in the middle of doing physio is when I discovered it as a symptom, But at the time it was basically, you sleep badly and, we need to get you a new pillow. So I've got a new pillow. And we were talking about this, how much money we're spending as we investigate what is going on, and I think for me, one of the important things about the education that you're doing and the education we're doing with each other as women is trying to shorten that period,
the learning
for
curve
you. The learning curve, and then maybe save you a little bit of money, and anxiety, because as you're doing that, there's an enormous amount of anxiety that is related to that. So what are some of the questions that you find are most, I want to say, pronounced? What keeps coming back for women during this transition?
The one that I find devastating is the one that the women know something is happening. I'm having an out of body experience. I am irritable. I am anxious. I have insomnia. And so the first question they have is, who do I see? Now, when your symptoms are cognitive and whatever, do you run to a psychiatrist, right? So you go to a psychiatrist and the psychiatrist is like, oh, I think you're going through depression. And so they prescribe you some antidepressants. And then you go home and you're like, okay, but now I'm having really bad hot flashes and blah, blah, blah. And then someone says, oh, maybe you need to go see your gynecologist. What I've been finding is women don't know where to go.
Okay.
They don't know where to find the information. They don't know which practitioner to go and see, because a lot of times, and especially how we practice medicine here is, if you have hypertension, we don't utilize GPs, which is what we're supposed to do, is you utilize your
Yes.
GP who will then refer you should
Yeah.
they not be able to manage. But we are all seeing specialists. So you can imagine going to a neurologist and saying, I'm having cognitive problems.
Yes.
And then they look, go through MRI, CT scan, that is expensive,
Yes.
And then the neurologist will tell you, well, your brain looks okay. So I really don't know what's going
Yeah.
on. So then maybe they'll prescribe something or the other, and then you're stuck again because that won't fix what's going on with you.
Right.
So a lot of times the biggest question is, who do I see? Yeah. And then remember, we are also practicing with, we have to unlearn and relearn and learn new things. And so a lot of practitioners, even in the gynecology space, they're telling, it's almost gaslighting the patient,
Yes.
and telling them, no, it's menopause. Just hang on in there. It will
Right.
pass.
Yes.
It will, and I tell women, menopause, actually, the menopause transition starts in the womb. Before you're born, you're already aging.
It started.
It started already. So I think it's mostly, who do I see?
Who do I see?
Yeah, that's one
Okay.
of the big ones. When it comes to cognitive symptoms, it's, am I going crazy?
Yeah.
Yeah. Many women report out of body experiences where you're having this meltdown and you're having this
Yes.
psychological
Yes.
symptoms that you can't recognize yourself. The people around you don't recognize you. 70% of divorces happen at this time and are initiated by women.
Yes.
It's because,
not that they're all bad. But
not that they're all bad. It's because they feel misunderstood.
Yes.
They feel unseen. They feel, it's not anything wrong with them.
Yeah.
It is just they are unsupported in this period.
Yeah.
So that is another one. When the cognitive symptoms show up, they're really thrown all over the place.
And the cognitive symptoms are
scary.
They're scary, but they're also fairly common.
Very.
And the research is telling us more and more about the changes in the brain during this transition, meaning that cognitive symptoms are not unusual.
Yeah.
In fact, it might be also that it's the severity that we notice, but also it might be the people who are really in tune with their bodies.
Yes.
Because,
I think it's not hard to tell. Let me tell you, the
but there's some
cognitive will
people-
come and you will realize.
But then there are some people who are not realizing that that's an issue, right? They're pegging it somewhere else, or you have people around you who are saying, hey, I think there might be something going on. And you're like, I'm fine. I mean, and I have friends, I'm sure you know people as well, who are like, I'm not going through anything. And it's like, hi, everyone's going to go through this.
Yeah.
I mean, your age tells you that you're definitely in this phase.
Yeah.
It's just which symptoms you have. And
correct. And some people may not have the cognitive. So it's probably,
They may
it's
not
actually
have the
coming from an
cognitive.
honest point. I'm okay. I'm not feeling any different. But for those who do, it's very obvious. And unfortunately, I say we're no longer having our children at 12 and being grandmothers and dying. So many of us are employed. We're in jobs.
Yes.
We're expected to perform. We are now the bosses. We're sitting in an office trying to have a conversation and the words go out the window and you're looking so incapable of,
Right.
and that's not you. And so
Yes.
it's, I've talked to women even the last few weeks who just left the job because they're like, I can no longer compete with Gen Zs and I can no longer keep up with the energy and I cannot, so you're pushed out of work because your cognitive function is affected and you can tell. Yeah. You can tell when it's there.
And it levels off.
Correct. Yes.
But that period, because it's such a difference from who you are. But you raise a really important point, which I think is one of the things that we don't talk about enough, which is sort of the cost of leaving the menopause transition unaddressed, both to women, but to companies. I mean, if you're losing your experienced, because at this point,
correct,
these are some of your most experienced people.
Workforce, yeah.
So if you're losing these professionals because you are either unable to understand them, unable to make accommodations for them, or don't even have, even a provision, let's say for even a sabbatical or something, what's the cost to you as a business? Then there's a cost to the individual, but again, also to society. What's happening when all these women are retreating then and removing themselves because essentially the society is not adapting to their changed needs.
The economic impact of menopause is huge. both in loss of income and in
Mm-hmm.
cost of the midlife diseases that we experience. So it's
Yeah.
a double whammy for those, for society in that
Yes.
way. Yeah.
And again, I think that goes to how important it is from a public health standpoint
Mhm.
to address this menopause transition.
Yes.
It's
Yes.
more expensive not to, actually. Let's put it
I
that way.
think so. Yeah.
Yes, yes.
Yeah.
So how can we systemically address some of these issues? You've talked about the community response and why that's important. What are some of the other systemic approaches that would be important?
We need a menopause policy. Let's start there, because
Okay.
looking at the reproductive health national guidelines with six mentions of menopause.
One of which is a definition.
One of which is a definition that has used it 3 times, and in
Yes.
one of them it's perimenopause.
Oh, wow. Okay.
The gap is so huge.
Yes.
And if we do not, now we are going through the shift and the showers and whatever, menopause is not addressed
Yeah.
at all. Which means we are totally exposed. But it could also go back to the fact that many women leave employment at this time, so they are not even there to be addressed. You know what I mean? It's like,
Yes.
who are we dealing with? Because I think civil service is a good ground where they base a lot of these
Mm-hmm.
policies on, because then
Mm-hmm.
that you have all manner of all
Right.
ages, and
Yes.
it's a
Yes.
good demographic to
Yeah.
work with. But if the women are falling off at 50,
Mm-hmm.
then they're not being addressed, because
Right.
even at 45 to 50, you're just barely keeping up.
Yes.
And then
Yeah.
at 50, you're
Yeah.
like, let me take early retirement and get out
And
of
just
here. So I don't think, they may not be enough voices in the demographic that they're looking at,
Okay.
to actually now speak up and say, we need to be included. It could be, I don't know what it is, but we need to work on
And
on that
I think
policy.
for me, what I'm hearing is I'm hearing your voice. I've heard Dr. Monda as well speak about this. And it does seem like a very obvious gap when we now interrogate the data around the risks of this menopause transition for women, the opportunities to treat it, which
Yes.
are increasingly available.
Yes.
So it does seem like a fairly obvious gap, maybe one that 5-7 years ago may not have been so clear, but the evidence shows that it's one that deserves response. So I'm hearing your voices. I guess what I'm trying to say is there are voices that can help inform this, and perhaps what we're saying is it's important then for politicians and those policymakers, health, aging.
Providers
I
too.
noticed in that reproductive policy they called us the elderly.
Geriatric and
They called us
elderly.
the elderly population.
Yeah.
And I'm like, wow, okay, I moved from reproductive prime to elderly. I mean, there's like no.
And I keep saying that is actually a global thing, because if you Google menopause and then go to images,
Yes.
they are all 70s, 80s.
Yeah.
They are elderly.
Yeah.
And so I tell people, don't, when you're writing these documents, remember that perimenopause can start at 35. So if you use that word elderly,
Yes.
it's a 35-year-old person you're
Yes.
putting in that elderly
and then it makes people not want to associate.
Correct. Yes.
Right. So I don't look like that. So obviously I'm not,
Yes.
and I'm 52. I'm definitely perimenopausal. I'm sure I'm about to just jump the hump any moment now. But again, when I look at some pictures, I'm like, yeah, but I'm not that, right? So of course that doesn't apply to me. So even the images can work to undereducate and uninform people, because then people are trying to distance themselves from a version of aging that categorizes them as obsolete. Because it's not saying you're still productive. It's basically saying, oh, at this point,
yeah,
time is up. We should put you up to pasture,
And I think I guess what people need to understand is a lot of these we were aged by our ovaries, right? So
yes,
it's how long are your ovaries functioning. And, they peak at late 20s. And then after that, it's downhill. Nobody tells you that. So when I got pregnant with my first child, And I thought, we've been growing up being told, don't you have children in my house? Don't be a teenage pregnancy,
Yes.
da.
Yep.
So even out of trauma, you're like, let me clear 30 well, before I even have the
Before we even
first
have,
one, right?
yes.
So you
I
have the
think a lot
first
of us
one.
had that trauma.
Exactly. Exactly. I think in my family, we are 7 girls and 6 of us had children after 30.
Wow.
First child. So when I think about it, and I'm like, when I went to the doctor, and the first thing, my file had a red sticker that said high risk, and then it was called a geriatric pregnancy. And I'm thinking, wow. I mean, that really threw me off. And I'm
Yes.
thinking, I'm
Yeah.
still having the time of my life. I'm still in my prime. What are you talking about,
Yeah.
geriatric?
Yes.
But they were using my ovaries to age me.
Yeah.
And it's like, as long as my age, so they're like, no, you're on the other, and this is your first pregnancy. So your womb has no experience. So we're working in the dark here. And so when I had my second, and I'll tell you in the difference in practices, because when I got pregnant with the second one, I was just turning 40.
Mm.
And I realized that the attitude of my doctor in Kenya, the first one was in the States, but second one, the attitude of my gynecologist in Kenya was so laissez-faire.
Oh.
She wasn't panicked that
Mm-hmm.
I was about to have a baby in my 40s. Then
Yes.
I'm thinking, 8 years ago, this story was
It
very
was very
different.
different.
I mean, I was
Yes.
high risk. I was this. And they told me, it's your age, it's your race, it's your first pregnancy.
Yep.
And then, so the second one, in fact, I used to be those shamers of who has a baby at 40. Guess who I was? That one. And I remember, the doctor, she was so relaxed. And I said, maybe here their aging is not as critical
Yes.
as,
Yeah.
and if you think about it, I had already started having the perimenopause symptoms of like no periods or whatever. So I didn't even know I was pregnant. I just thought I was having my usual
Just a
sabbatical
long
from
break.
period that comes and goes and comes and goes.
Yes.
And so I found it very interesting. I said, does that affect? I don't know if she's representative of the practice really, but the way she handled that situation was very interesting to me, because I thought she would be. And then I went to the States to have the baby. And the day I landed, I was sent to a high risk pregnancy specialist.
Back to your geriatric.
Yeah.
You are, yes.
Once I landed, they were
Yes.
even like, what do you mean you just, okay, I hadn't just found out, but they're like, didn't your doctor order this test? Didn't your doctor order? I'm like, I even suggested it. She's like, no, you're
Yes.
good.
Yeah.
And so on the other side, I think that there's a lot more effort, or rather, indicators that you need to be thinking about something or the other. It was really laissez-faire on this side. So I don't know if that's why many of us have been caught unaware. Because the minute they said I was a geriatric pregnancy at 32, I started thinking like, okay, 32 and geriatric pregnancy.
Yes.
And so that triggered my thought. Like,
Yes.
that's why if I'm geriatric now, I have no business, or I shouldn't have any business having a child at 40. So that even informed my stigma and my,
Yes.
attitude towards that. But I think it's maybe the reason why. I think the doctor here should have been concerned about, okay, you're also quite advanced in age as far as your ovaries are concerned.
Yes.
So the fact that she wasn't sure, I think that's why women are being shocked. Like, what do you mean? I just had a baby at 40.
Yeah.
My doctor didn't say anything. My life has been going on. And yeah.
Everything seems to be
But
fine.
you can have the baby now, and even already had been perimenopausal.
Yes.
Like I said, I was.
Yep.
So I was missing my periods 5 months. They come back when they want to come. But, and I wasn't concerned, because I'm like, I really don't want them.
Right.
Yeah.
Right.
So many people are surprised because the information is not trickling down to the people, the individual.
Yes.
Yeah.
Yeah. And actually, when you say that, it's interesting, because I had my second child at 38 as well. It ended up being a high risk pregnancy, and I was hospitalized for last part of it. But it did seem to me that this is more normal. It wasn't abnormal to be dealing with women at this stage, which also raises then the issue of, we're going through this whole transition and we've got kids at home.
Correct.
Right?
Yeah.
Some of them are, in their tweens, and then we've got teenagers. So we've got this double whammy of hormones in the home. And without some tools about how to explain and engage with each other, the risks to the family structure are also pretty high.
Mm-hmm. And I tell people this is the time many teenagers and parents fall apart. I mean, their relationship is on the rocks, so to speak. And I think it's also just the fact that we don't talk about it enough. Children are so perceptive. Children are so smart.
Yeah.
They just need to know. And in my household, I have a teenager and I have a preteen. And I found that our behavioral problems are sorted by having these conversations. So, for example, if I'm not in the mood for nurturing, if I say, I just want to be alone or I just need my time, my kids understand. But they are drummed with menopause every day.
But
In fact,
maybe I think this is a good segue to tell us then, how do you have this conversation? How do you start? Don't assume it's your kids who have been hearing about it. So how would you start having this conversation?
The conversation about reproductive health starts when they're little, right?
Okay.
So you talk about them and talk about their body parts. You talk about the basics, identifying and you talk about both genders, not just what's affecting your child.
Okay.
So my children are, they have two boys, but they are aware there's vulvas and vaginas and there's periods and girls this and they are
right.
But the conversation is always progressive, and every time a question comes up, you build up on that and build up on that. So, for example, before we even had the menopause conversation, they knew mommy has periods and she has periods once a month. And many times I'd say, I'm on my period right now, so I don't want to have to do whatever activity, or I'm not in the position to do that activity or whatever. So I find that it has to start from when they're little and it builds up and builds up. And that's why menopause can be had. The conversation about menopause can be had because you've already done the building blocks until that point.
Okay.
So
if you haven't, because I mean, what are you going to do? You can't take them back. I mean, I'm sure there are parents who, maybe stumbled. They now have teenagers. What would your advice be to them?
So what I do is I also talk to teenagers. What I find is many times the conversations that I had, girls have them. They have period parties. They have this, they have that. Now, when I talk to, I've never attended any of them. I kept saying I should. But when I talked to the educators who run those programs, they do talk about menstrual health. But then there's things that are not touched on as far as reproductive health is concerned. So, for example, I tell people teenagers have a hard time remembering things. As much as you give them so much credit for having to do exams and whatever, they have a problem. That's why you'll tell somebody, bring me a glass of water. And by the time they leave the room, it's out of their head, which is the same as us, right? In the perimenopause stage. So I find that we don't address puberty. We'll talk about, the boobs will come, the deep voice will come, whatever, but then you don't tell them about the cognitive issues that they're going through, the musculoskeletal issues that they're going through. Their bone density is just now building up. That's why they're always having fractures. We don't talk about the big picture, about the clumsiness that comes. Exactly.
Yes.
So, they'll be clumsy and they'll be chewed out for it. But nobody's thinking that, guess what?
Yes.
It is part of being a teenager.
Suddenly the arms are a little longer than they were.
And I tell my son that, I'm like, sometimes, you tell your son to pull the curtain and then they pull it too hard and the whole thing comes down. Because today they are stronger than they were. They don't know their own strength from day to day. And so those are the things that I say. We talk about menstrual health, we talk about menstrual hygiene. We don't talk about the whole picture, which has so much else going on other than a period. And other than, you need to use condoms or whatever. We don't. We do talk about sexually transmitted diseases, but even puberty. And I tell women, puberty and menopause are mirror images of each other. So when I explain it that way to my kids, they get it.
They're like, you're going through what I'm going through.
Exactly. So when I send them to the kitchen and I'm like, go get me a knife, and they come back with it, I'm like, oh, we are having pre-puberty, brain. Okay, let's try this again. Can you please go? And then, of course, I'm calmer about it. So I don't have to yell and shout and you never listen. And how come you can never remember anything? It's not that. It's, I get where you're coming from. How about we try this again? And it's the same with me.
And please give me the same grace.
So they give me the same grace. So when, in fact, we call it menopause brain and we call it teen brain. So it's like, Oh,
Okay.
we're having teen brain moment.
Mm-hmm.
Okay, how about we try this again?
Okay.
Go do this, go do that. Yeah. So
I
we
think
don't
that's
shout and slam doors in my house. There's no need.
there's no need because you're
No,
having
because we're
conversations.
having conversations all the
And I
time.
think that that's helpful because there is an important need to explain to the people around you enough, at least so that they can, be around you. Because, when you're going through this and it's rough,
Mhm.
And you're having trouble figuring out yourself,
Mhm.
it's difficult to have people who love you and you can see they're struggling, but they have no way even of reaching you because you're
Yeah.
just like, listen,
But the reason why they can't reach you is because you haven't maybe communicated
Yes.
effectively for them to understand, because they love you, so they want the
Yes.
best for you.
Right.
So
Yeah.
whatever they can do to help, they will. But they
Yeah.
just need to understand what
And they
it
can't be the
is.
ones telling you, mommy, you have a problem,
No,
right?
they can't.
Yes. Not that they want to live. So
True. Yes.
yeah. So tell us then. I know the Women's Health Cafe has really been a trailblazer in terms of menopause, and you've been. I'm telling you, and I need you to own it. You really have been a pioneer in terms of really demystifying menopause and menopausal education, making it more accessible. And I think one of the things that is particularly helpful about being part of the Women's Health Cafe is how you break down complex subjects. So
Mhm.
you pick a topic and you break it down, and you aren't knocking us over the head with medical terms.
Yeah. Yeah.
You're really, the language is accessible. You answer lots of questions. I think you might want to start doing a 10 bob per question or something, because I sometimes see a
I
question and I'm
know.
like, man, didn't she just answer this
I
question?
know. And that's why the WhatsApp space is kind of hard, because if you join it today, then you don't see the conversations that have been
Right.
had before. But yeah.
But tell us about what that is doing, how that's growing, in terms even for you. I think that's one of the challenges you're talking about now, which is we start with this group, but people are constantly coming in, so the education needs to be refreshed. So what are some of the things that you're doing to make sure that that education is spreading?
Okay, so one of the things that I have done is, some of the groups, if you notice, have different admins. For example, the fitness gurus run the exercise and
Yes.
fitness group.
Oh, those guys are a bit scary, man.
They are quite. But I love their motivation. I
it.
love their information. I love how
Yes.
and they don't tire. Ellie
No.
Mathenge she's just amazing.
Oh my gosh, she's
She
indefatigable.
doesn't
Yes.
tire. It's like, okay, I'll break it down again.
Yep.
How many proteins you need, how many
Yes.
grams every day, how many squats are,
Yep.
I'm like, bless Ellie, Mathenge, and Sifa. They have such patience.
Yes.
And then, of course, because some groups the information is cross informational. So it's like, okay, somebody asks it in the fitness group, and then it's asked again in the menopause group, and then somebody in the gynecology group. And I'm like, oh, they're so patient, those ladies. And I appreciate them, and they do it voluntarily. And it's amazing.
I'd love to have Ellie and Sifa, actually, because I do think health is huge. And there's some great health enthusiasts out there. I am a reluctant exerciser.
Yeah.
But I've also found that just being a member of the group, the energy is contagious.
The energy is contagious.
And I may not get to, I can't do those day challenges. But, I might do my 10.
It prompts you for it to be present for you.
And I do more than I would without being a member of that group, which, I know there's been some issues about people who just sort of are in the group and don't talk very much in various other groups. But yes.
Group dynamic manenos.
Dynamic manenos. So yes, of course, there's that. But there are other things that you're doing. You speak at conferences.
So I speak wherever I'm invited to speak. I create opportunities for myself to speak.
Yes.
But my motivation is just educate these women. That's the basic, because I started the Women's Health Cafe for two reasons. One, to educate the women. After meeting many women who didn't know the difference between their vagina and their urethra, right? I think yesterday somebody posted and said, can you imagine, I tried to put a tampon up my urethra. How?
Wow.
Right? So I'm like, so do you even know your own anatomy?
Yes.
Right?
Yes.
So it was to stop women from living lives not knowing what's going on with their own life. Do you know you have an ovary? Do you know you have a cervix? Do you know what each function is?
Yes.
Do you know what a hysterectomy looks like? Many women go through hysterectomies and don't even know what the doctor removed and what the doctor left. Right?
Okay. Yeah.
So it was for women to be empowered with education and information, because
Right.
once you're empowered with education and information, now you can ask the right questions.
Yes.
Right?
Without that knowledge, you're unable to really
Yes.
meaningfully
So my
engage.
experiences, one was when I was a teenager and my period was just not coming as regularly. And I went and told my dad, and the first thing he did was send me to see a gynecologist. And I remember putting, the nurse was
Okay,
prepping
you
me.
do know that every Kenyan who's listening is wondering why you went to tell your dad.
Oh, my dad was my guy, my person where you go to with all. Anyway, he was a medical doctor,
Yes.
so he was the right person to tell. Anyway, so he took me to see the gynecologist, and there was first of all the walls were paper thin between rooms, and the gynecologist was in one room, and I was being prepped by the nurse in the other room, and all I could hear is the gynecologist telling not even telling the lady, telling anybody who's passing or would listen, this lady's uterus has to go, and it just has to come out, and there's no saving it. And in my mind, I'm thinking, what is uterus? And what is this thing? I had heard,
Yes.
But that made me wonder if the lady who was listening to that first, why was he telling everybody else but her?
Right.
Right. So even when he walked into my room, he was there still talking
was still
about
having that conversation.
Yeah. So he's doing a vaginal examination,
Oh,
and he's
God.
saying that uterus is really bad.
Oh my God.
Bedside manner was not it.
Yeah.
But after that visit, I was put on birth control. I was 15, and I thought, is it necessary? Those were my questions. Was it necessary? Because when I asked why, I was told, you just need to have a regular period. I said, why do I need a regular period?
Yeah.
And I had no intentions of having children. It was like, please. What I really needed to be told is, just like menopause, when the cycle changes, in puberty, it takes a while to stabilize.
Right.
You don't come out right out of the stable with a 100-meter dash. It builds up,
Yes, it takes some time.
It takes some time for it to ever get regular like it should. And then it gets regular in your 20s, and then it starts getting, somebody should have told me that, because if I knew that, I would have opted out of the birth control. I really didn't need it. It was going to stabilize at some point.
Eventually.
Now, what I should have been told is, if you get to this point, and it hasn't, then we need to do something. And and honestly, I think for me, it would have only been related to childbirth. If somebody told me, oh, you don't want to have children, then don't, I would have just left it. I would never have done anything about it. Then I would have found another way to permanently deal with that, like ligation or whatever. But yeah, it was just not communicated fully.
So, and you're saying something that's super important, which is that women need to understand that this information is necessary to actually meaningfully engage with your doctor.
Correct. Yeah.
Without this information, it's not a nice to have. It's not, I don't have signs and symptoms, so I don't need it.
Correct.
It is that without this information, your ability to actually get the best medical care is compromised.
Yes.
Yeah.
And you see, I tell people, let's say, for example, you go to your doctor and you have endometriosis, right? What are my options?
Where endometriosis is?
Or in the uterus. What do you mean?
What is endometriosis? You're just talking to us like we are all.
Let's even take fibroids, which are the growths that happen in your.
Yes.
There's so many different in your uterus. There's so many different treatments to approach.
Right.
To approach fibroids. But many women I've talked to in the last few years, they'll say, "Oh, I had a hysterectomy. Why I had fibroids? Okay, were you offered a mammectomy? No. Were you told there's the option to just remove? No. Because it's okay. It may not be ideal for you, but you say, what about a mammectomy? And the doctor might say, oh, I don't feel it would be right for you. Or is that something you want to consider?
Right.
Or is it, there's so many other options before we get to removing. Because, every time you remove, I remember when I was a kid and I used to have tonsillitis really bad. And my dad was like, you know what, we're just going to have to snip them out because this is too much. I was in and out of school so often. I remember my mom saying, you don't think that when God put that tonsil there, he put it there for a purpose? So you're not going to take it out of her. You're going to figure out how to keep it because it's there for a reason. You don't know, we're even talking about the uterus. Yes, we go in and we take out the uterus. But how do we know that the uterus doesn't play a role in our endocrine
Yes,
health? Health. You don't know.
Right.
So there's always something that happens once the hysterectomy is done. Why aren't we addressing that? Let's even talk about hormone therapy, right?
Yes.
For women without a uterus, what do we do? Estrogen only, right?
Okay.
Why?
Mhm.
Because estrogen, we know
Yes.
estrogen has functions all through our bodily systems. It's the
Right.
same with progesterone. So why
Yes.
aren't we replacing progesterone in them too? Their cognitive function,
Yes.
their bone health, progesterone has a role in that. So they're also not fully being addressed
Right.
because we are assuming, we call it bikini medicine. We're
Yes.
just focusing on the
Focused,
uterus.
yes.
But there's many other functions in their body that progesterone is not being provided for.
I mean, I have to admit, it's feeling a bit exhausting. It's just feeling like this is a phase where you need to be super engaged with your health.
Yes.
Which I don't think is the message that we've gotten most of our lives.
No, nobody told you that. No.
Yeah.
No.
Yeah. And that there are consequences to not knowing, not being able to ask certain questions, because you then live with the choice, if it can be called a choice, if you had one procedure done vis-a-vis others and you did not have, sort of a discussion about which one to have done.
And like I was talking about the hysterectomy, where, you have your hysterectomy at 32 and nobody tells you
Yes.
that at the normal age of menopause, regular age or natural age of menopause, you're probably going to have symptoms and probably even worse than before. Nobody tells you.
No one's having that
So you wake up one
conversation.
day and you're like,
Yes.
I haven't had a uterus for 18 years, but what symptoms are these?
Yes.
And you're like, nobody told you that you're still going to go through natural
So
menopause.
again, you start doing that. What's wrong with me?
Exactly.
You start doing a specialist.
Yeah.
So, okay. So I think that for me, one of the things that you are highlighting, which I think is critically important for women, is this specialist approach that we have might not be great for us during this phase of life. It might be important to have a primary care, a GP of some sort, just somebody who's sort of a reference point to keep going back to, and who has visibility of sort of the wholeness of you.
The same way a GP is trained to take care of even pediatrics and adolescents,
Yes.
is the same way they should be able to manage menopausal patients. That's just how it is, because it is a public health concern and affects so many.
Right.
We really don't need specialists. We need GPs who are empowered.
Yes.
And then for the special cases, remember there's the other conditions that come with menopause,
Right.
with aging.
Yes.
Then they can deal with the specialized cases. But
Yes.
menopause on its own, being such a natural transition affecting so many, we just need people specially trained, because it wasn't done in medical school.
Yes.
But it needs to now be highlighted in
Right.
medical school.
Yes.
Yeah. Or we can have, just like we have pediatricians, we have
Geriatric
doctors and specialists. But you see, again, it sounds like it's a thing of the 70s
I would definitely
and the 80
not be going to the geriatric.
They're called geriatrologists.
My kids would have to be taking me with a cane.
Yeah,
yes, at least that's my image.
Yeah,
Yes.
so we just need another specialty added to the middle age, because we're not on one side and we're not on the other side. We're just here smacking. We're still productive in society. We're still raising kids. We're still, so that is a totally different demographic from, for example, my mom. My mom would have been now geriatric, because that is 80s and
Yes.
yeah.
Okay, well, that's helpful. I really do think this public health space, there's an enormous amount then that can be done even before we get to the policies, it sounds like.
Correct, which is what the Women's Health Cafe is.
Yes.
It is actually addressing a public health concern. It's a public health vessel.
Yes.
Addressing all these women at the same time, empowering them to prevent disease, to promote wellness, to prolong life.
Yes.
Those are the conversations we have.
And hopefully that will also be an avenue for then advocacy around a menopause policy and menopause coverage and insurance.
So
and
I'm
other
trying to
areas.
get these women to a point, and I think I say it every so often, hopefully we get the numbers to be able now to start collecting our own data.
Yes.
Right now we're at 1,700 women. It's interesting. We've grown 200 women in the last 1 week.
Wow, what happened? And these are in bots because it's WhatsApp.
I think we celebrated our 1-year anniversary, and I'm like, oh my gosh, it's 200 people in 2 weeks. And
for our listeners, it's 1,700 women who are not just in Kenya.
No, they're all over.
They're all over.
Yes. So I found it the fact that we are growing, I'm thinking we'll get to a critical mass where if we can find ways to tap into that group of women to now get data that is, there's a lady who told me, I wish you could come to Cameroon. She's from Cameroon. She's
Yes.
like, I wish you could come to Cameroon. And so I said, well, let's see how this group works as far as collecting, even just when did you menopause?
Yes.
When did you menopause? Hopefully we can draw a graph and say, okay,
Yep.
Kenyan women are menopausing at 48, or
Right.
rather that's
Yeah.
the median age or whatever. It's a start to
Yes.
start. It's a basis for us to be able to start getting our own data. So that is a long-term plan. Yes.
Yeah. But, the conversation should be in Cameroon. We will share it on our group. And I think you provide, even if we are not gathering our own data yet, we're giving ourselves enough comfort that is necessary.
Yes.
So that if somebody approached me or you today and asked for that data, we would actually understand.
Yes.
We probably wouldn't be as skeptical as we would have been, 5-7 years ago if somebody was asking us. And you haven't said this part, but because I've spoken with you, I know this part. It's not just collecting African women's data. It's African women collecting and analyzing this data.
Yes.
We're not talking about, some great Western philanthropist coming and doing. We're saying that this is work that is important for us to do because there's an understanding that we have about ourselves and about what matters to us. That means that even how we analyze that data is differently.
It's different.
Yes. Thank you. Thank you so much for coming and for having this conversation. I could talk to you for...
I know.
Yes. And I already have some other questions, but I think this is a great first conversation and I'm glad we've had it. We will have details on how people can contact you if they'd like to speak with you or have you come in and speak. But I would want to encourage you to continue being this menopause champion for us.
I have no intentions of stopping.
Oh, good. Fantastic.
Yeah, this is my retirement career.
Oh, good.
Sail into,
into geriatric.
Into geriatric. And then also, I think this is of all the things, anybody who knows me, I think of all the things that I've ever done in my life, it always has to be around people. I thrive on people's energies. I thrive in spaces where there's people. And so I was like, this is it. This one I have settled. Before I was doing regulatory affairs with pharmaceuticals, and I'm like, you're talking to papers or fighting with someone to release something for you or whatever. I was like, that's not how I'm going out.
Yeah. You've pivoted.
My big age does not allow me to be doing that. So I'm really enjoying it.
Oh, I'm so glad you're doing this. I know very many women's lives are different because you're doing this.
Yes.
And different in positive ways.
Every day I get phone calls from women like, this group has saved my life.
Yep.
Our conversation saved my life. Just this morning, this lady just came and said, do you know, I've just come from spending $500,000, Bob. I've seen neurologists, I've seen psychiatrists, I've taken antidepressants. I had an ear infection that was this, that, and I'm like, wow. Ouch. Now she was like, I came to the Women's Health Cafe and I was like, where have I been in the wilderness all this time? But she also has peers who are stigmatized and in denial. So she's like, every time she brings it up, her friends are like, these are not things we talk about in public.
Right.
She's like, but we are a group of women, all of us going through the same thing. And she said, even she wound up going into the isolation and because of the anxiety and the panic attacks and and the doctors would tell her, oh yeah, panic attacks also cause that hot flash, So she believed that her hot flash was being caused by her anxiety, which she was given medication for, which was the total wrong
medication.
Yeah.
Yes. So creating these spaces where we can publicly speak about menopause and the menopause transition for women and hopefully destigmatizing it for ourselves, but also for others is work that I know you will continue to do and hopefully we will continue to do as well. So thank you so much for joining us at Orusa. That is our second episode where we speak about the power and possibilities of menopause with a particular focus on African women. I'm hoping that we will have you again.
Yes, and maybe people need to know how to reach me.
Yes, so we will have those details in the...
Well, for one, you can always go to the Facebook. We're on Facebook and LinkedIn. I forgot
so
to
give us
mention
our
LinkedIn.
Facebook.
So Facebook is Women's Health Cafe.
Okay.
And you just need to send me a message. You can send me a message, you can WhatsApp from there, and then you can reach me that way.
And LinkedIn?
And the same way with LinkedIn. Send me
Okay.
a message or WhatsApp on there, and you're
Okay.
good. Yeah.
Fantastic. So, and if you want to get into the Women's Health Cafe, you need to know somebody
Know
who's in.
somebody who's in it. Or know me.
Yes.
Or know me. Yeah.
Thank you very much. And we look forward to you joining us again.